panelists and attendees members. I am Sumit Saurabh, host for this webinar at NV. I request Dr. Srikant Basu to kindly start this session. Thank you and over to you, sir.
Thank you, Saurabhji. Good evening, friend. Good evening, students. Today we are going to take a very common but very interesting topic, that is approach to nutritional anemia. And to take you through this webinar, we have with us Professor Dr. Jagdish Chandra sir, who has been my teacher at the Lady Harding Medical College and Kalavadishwaran Children Hospital, where he was heading the department and became a director also. He is authority on hematological and oncological disorders in children, and he has many publications and chapters to his credit. Recently, he and his team has come out a guideline on nutritional anemia, which I'm sure he will going to discuss today. And as usual, at the end of the session, I'm sure he will going to have many questions, as this is a very common topic, not only for your day-to-day practice management, but also for exams as well. Over to you, sir. Thanks, sir.
Thank you, Dr. Srikant, for that kind introduction. So, good evening, dear students. As Dr. Srikant said, that it's a very common topic, and still it is something which probably needs to be deliberated again and again. You would realize that anemia prevalence in our country is still very high, and this is the CNNS survey of 2016 to 2018, where the prevalence in preschool children was 41%, and school age children 5 to 9 years 24%, adolescent another 28%, and etiology of anemia was nutritional in about 70% cases under 4 years, 5 to 9 another 50%, and 10 to 19 that is 65%. And certainly iron deficiency was the commonest in under 5, while folate and B12 deficiency were higher among the school going children and adolescents. So this is the condition as of now, and though I have given you the figures of CNNS survey, but NFHS survey is even more disturbing. You can see that the survey which showed in 2015-16, NFHS 4 showed 58% prevalence of anemia in 6 to 59 months of age. It has increased in 2019 to 21 to 67%. This is despite all the programs that we have. Over the last 50 to 60 years, we are running several programs for anemia control, anemia prophylaxis program, control program, and now of course this is the Anemia Mukt Bharat program, and iron supplementation across age groups, that is from 6 months onwards to later ages, is recommended in that program. Despite that, the prevalence of anemia is not decreasing. So these are the deficiencies. When we look at the deficiency anemia in children, this is in under 5 years, you can see that it's not just one micronutrient is deficient. It is generally a combination of iron with folate or B12, iron folate combination or iron B12 combination, or iron folate B12, all three combined deficiency is there. Similarly, among adolescents, the combined deficiencies are very common. You can see here under 4 years, the proportion of iron deficiency being 32%, 23% being deficient in folate, and 13% in B12, while in 5 to 9 years, the folate deficiency increases to 28%, and iron and B12 deficiency is around 17%. So in adolescent age group also, folate and B12 deficiency is much higher than iron deficiency. So it's a combined deficiency of iron, folate, B12, and in several different combinations, as I said, is this does occur. So we will begin with the diagnosis and treatment of iron deficiency anemia. And I hope that many of you might have come across this publication in Indian Pediatrics, October 2022, which is on the recommendations on diagnosis, treatment, and prevention of nutrition anemia in children. In fact, it came to me as a surprise when we worked on this that this is for the first time in the world English literature, the guidelines exclusively for pediatric age group is available. And if you look at the adult iron deficiency treatment guidelines, there are almost 35 to 40 sets of guidelines available. But pediatric guideline, this is the only one which has come up in October 2022. So a large part of my talk would be based on these because this was a very thoroughly worked up document, and this would be discussed in detail. So the first diagnosis, first recommendation in this was that how to define anemia, and these are the cutoff of hemoglobin which were described. So it is recommended to use existing hemoglobin cutoffs, that is WHO cutoffs, which are there in the table. You can see 11 under 5 years, then 5 to 11 years at 11.5, 12 to 14 years 12, men above 15 years 13, women above 15 is 12, and pregnant women 11. So these are the cutoffs to define the patient is anemic or non-anemic, and then mild, moderate, severe depending upon the age and cutoffs which are described. Now, why it is important to give this recommendation is that 2-3 years back, one article appeared in Indian literature which was talked about much, that probably in India the cutoff of hemoglobin to define anemia should be different than what WHO cutoffs are. So these cutoffs they describe all that the cutoffs would be something like 1.5 to 1.9 gram across different age groups would be lower than the existing WHO cutoff, but government programs still use this definition, and WHO also has reiterated that till we have more evidence, we should persist with these cutoffs to be used for diagnosing anemia in children. And these are the various cutoffs to define microcytosis, macrocytosis, and the cutoffs for serum ferritin. So you can see that microcytosis up to 2 years of age, the cutoff is 70 femtoliters. 2 to 10 years, you can use a formula 70 plus age in years, and more than 10 years, it is less than 80, right? So this is the cutoff to define the microcytosis. Similarly, for macrocytosis, between 2 to 10 years of age, it is 84 plus 0.6 into age in years, and above 10 years, it is more than 90. And these are the WHO cutoffs of ferritin, which are written here for defining iron deficiency. A cutoff of less than 12 for under 5 years and less than 15 for more than 5 years of age. And if the patient is having associated infection, then the cutoff used is less than 30. The other cutoffs are there for serum transferrin saturation and reticulocyte hemoglobin. We will discuss what is this reticulocyte hemoglobin, and there are some newer tests becoming available. Percentage hypochromic cells, like there are electronic cell counters which will give you what percentage of the RBCs in the given blood sample are hypochromic. So a cutoff of more than 5 or 6 is recommended to be used for defining iron deficiency anemia. And similarly, the cutoff of pre-erythrocyte porphyrin. This is just to complete the list of investigation, though this test is very sparingly used, and in research settings only this is being used. So if you look at the physical examination in children with iron deficiency, there are no significant findings except pallor, no or just palpable liver and spleen, no bleeds or lymphadenopathy. Cholionicia and platinicia is something which is described in the literature, but let me tell you that in the current situations we have not seen this much. This has somehow it has got stuck in the literature that these are the findings. Maybe in good olden days when iron deficiency more severe forms were available and we were seeing that. Be careful in looking for clubbing in children because that would point towards the etiology of iron deficiency being celiac disease. So now recommendations for diagnosis of iron deficiency or iron deficiency anemia. This set of recommendations said that in most clinical situations, a presumptive diagnosis of IDA can be made based on red cell indices and the blood picture suggestive of microcytic hypochromic anemia. But it also highlighted that in all such cases where you have made a presumptive diagnosis, response to iron therapy should be documented for confirmation of diagnosis. Now, why this recommendation has come up is that in large parts of our country, serum ferritins are still not available. And when you order iron studies, please remember that iron studies alone, they are not recommended for diagnosing iron deficiency. This is listed here. Serum ferritin should be the first test to diagnose iron deficiency or IDA, where investigative workup is indicated. In situations where serum ferritin results are equivocal, then transferrin saturation is something which is used rather than serum iron levels. So serum iron levels are done to calculate the percent saturation of the transferrin. And similarly, the other recommendation was that CHR and RET-HE, these are the reticulocyte hemoglobin content, and percentage of hypochromic cells wherever available can be used to diagnose iron deficiency anemia. We'll elaborate on these. So as I said, in most clinical situations, a presumptive diagnosis can be made, and based on the clinical things like at-risk infant, that is preterm, low birth weight, or during the rapid growth period of adolescence. There is dietary history, which is poor transition to complementary feeding, or more milk is being fed. Clinical features, breath holding spells, and history of pica. Now, please remember these two are very important pointers towards the diagnosis of iron deficiency. Breath holding spells are proven to be because of iron deficiency, and you give therapy with iron, and you can show that there is regression of these breath holding spells. Similarly, pica also in 2 to 3 weeks' time it disappears. Another thing is that cases with febrile convulsions are more likely to have iron deficiency. So, in these cases, peripheral blood picture would be suggestive of microcytic hypochromic anemia, with of course an isopoikilocytosis would be there. Coulter report, which is there on the right side of the panel, you can see, and a triad of low MCV, low MCH, and low MCHC for age is consistent with the diagnosis of IDA. And in all such cases where the ferritin has not been done to confirm the diagnosis, please document the response to iron therapy. So one should not have this impression that we do not have the serum ferritin available. So how to diagnose? So you can diagnose on the basis of MCHC, MCV, and MCH, and then show the response to this. So serum ferritin is recommended as the first test for the diagnosis, and these are the cutoffs of WHO 12 and 15, under 5 and over 5 years of age. And these recommendations are across the world literature, even in adults. British Society of Hematology also uses this, and with infection, as I said, a cutoff of less than 30 is. So iron studies, there is day-to-day variability, therefore we do not use this much, but estimation of iron alone is not recommended. It is estimated to calculate the transferrin saturation of TIVC, and iron studies are recommended when serum ferritin results are equivocal. So, and these are like, if you are seeing a microcytic hypochromic blood picture, there is a setting of deficiency anemia, ferritin is say 16 or 17, right? So you do not go away with this idea that you can rule out iron deficiency. No, take it in conjunction with the clinical picture. So clinical picture and peripheral blood picture, and then if the ferritin is around 20, you take it as iron deficiency and then document the response to iron therapy. Now, reticulocyte hemoglobin content. Actually, this is something new, and on 7-part electronic cell counters, you get this. And in both Sysmex and Coulter, the one is labeling this as CHR, and the other is labeling it as RET-HE. So basically, it is reticulocyte hemoglobin content only, and this is getting popularity for diagnosing iron deficiency, particularly in cases with chronic renal failure. You can imagine that there would be anemia of chronic disease as well as anemia related to iron deficiency also. So this test is very useful because ferritin would go haywire in such situations. And when you have this erythropoietin therapy to be given, So you need to be sure that iron deficiency has been taken care of. Therefore, this test is very useful in those situations. So the you can see here to the last parameter you can see in both the reports. The red HE of 25.4 and the another showed 29.3, and both these are macrocytic anemia. So the B12 folate deficiency in one was associated with iron, and in another it was not associated with iron. Right? So with this, moving on to how to treat iron deficiency anemia. So aim of the treatment obviously is to provide iron therapy in appropriate dose, appropriate formulation, and for appropriate duration to restore the hemoglobin to normal range and deplete body iron stores. So comprehensive treatment of IDS should include identification of any secondary cause and manage it. And treatment must also address dietary modifications and periodic follow-up for assessment of therapeutic response. That is also very important. So again, these guidelines for the first time highlighted once you start iron therapy, when you should call the patient to for the assessment of the response, and how to handle uh, the non-responder patients. So these are the iron salts. You are all familiar with this: ferrous sulfate, fumarate, and iron amino acid chelates. So, but fumarate, gluconate, and ferrous sulfate, these are the common salts available. Though iron polymaltose complex is also there. So, oral route we recommended was safe, effective, economical, and leads to rapid improvement in hemoglobin if it is administered in the correct dose and followed up appropriately. And of course, it is convenient for the patients, and it is well tolerated by almost all patients. Right? So, oral therapy is something which is recommended. Again, it's important to realize here, because in adult iron deficiency anemia, there is a talk that since lot of IV iron preparations have become available, which are very easy to administer rather than infusions which were given some 10 years back. Now it is a IV push, and why give daily tablet, and they somehow the adults do not tolerate oral iron therapy too well. But in children, it is recommended to be the first line therapy, that is the oral iron therapy. So the recommendation was to use sulfate, fumarate, or gluconate. And please remember that you have to know the elemental iron content of these, the sulfate, fumarate, and gluconate. And there is very little to choose between these three, because they are equally effective, and they are almost same price. So price becomes important, because if you give treatment for something like 6 months, roughly 3 months time is taken for hemoglobin to normalize, and after that another 8 to 12 weeks, that is another 2 to 3 months for replenishing the stores. That means 6 months therapy is required, and cost becomes an important factor here. So we did not recommend use of prolonged release or entry-coated tablets or liposomal iron formulations. The dose recommended was 2 to 3 milligram per kg of iron per day, and of elemental iron along with folic acid, given for up to 2 to 3 months after hemoglobin normalizes. And single daily dose of iron is recommended. Divided doses can be given in cases with gastrointestinal adverse effect. While on treatment, patient with severe anemia should be called for first follow-up on day 7, while patient with moderate and mild anemia should be called for follow-up on day 14. Right? So let us see this in detail. Why dose of 2 to 3 milligram and not 5 to 6 milligram? Because it has been observed in a very recent study, excellent response observed with 3 milligram per kg. And if you look at the British Society of Gastroenterology, which published its iron deficiency treatment guidelines for adults in gut 2021, they recommend 1 to 2 tablets of iron sulfate, and that tablet in UK contains 66 milligram, like our ferrous sulfate tablet contains. So, if the adults can be treated with 1 milligram per kg to start with, or at the most 2 milligram, why children should receive who have better absorption of iron, why they should be receiving more. So, and why single dose and why not divided doses? So, you must have heard that divided doses probably tolerance would be good. But here the issue is that if you give the fraction of iron absorbed from the second dose of the day is much less because of the hepcidin response. So it is recommended that single dose should be used, and it has been shown that single dose given leads to better reticulocytosis compared to if you give split doses. Certainly, because the second dose that you are giving, from that the iron absorption is much lower compared to if you give the total two doses combined as a single dose. And of course, with single dose, it is expected that long-term compliance would be better. And for administration in the evening after dinner, improves gastrointestinal tolerance. So this is gastrointestinal tolerance is better after given after dinner. And another reason is that the gut transit time is delayed after dinner when the patient is sleeping. So the iron absorption, the iron take gets more time, more exposure to the intestinal absorption. So absorption is also much better if it is given after the dinner at the bedtime. Duration we have talked about, and how do we assess the response? Initial improvement of appetite and general well-being comes as early as 24 to 48 hours. Compared to mild or moderate anemia, rise in reticulocytes is much higher in severe anemia. Peak reticulocyte count is seen on 5 to 10th day following iron therapy, and the rise of hemoglobin is 0.25 to 0.4 gram per day, or hematocrit rises 1% per day from day 7 to day 10. So in 2-3 days time or 4-5 days time, the hemoglobin rise will be minimal and very difficult to decipher, because day-to-day variability in the electronic cell counters also would be there, and you cannot decide if it was 6.5 before starting treatment, now it has become 6.7, whether it is really increased or not. And thereafter is slower rise of 0.1 to 0.15 gram per 0.1 to 0.15 gram per deciliter per day is seen in hemoglobin. So on day 7, when you call, you look for whether the child is tolerating the drug is being given properly or not. If there are any adverse effects, then you can modify the way you want to modify, and tolerance of the therapy, and you can assess the clinical improvement going by the improvement in appetite and general well-being. And if the patient had pica, or if the patient had breath holding spells, within that 7 days time there would be some decline in the frequency of breath holding spells. If the patient was having daily 2 to 3 episodes, it might decrease. This is how the hemoglobin rises. This is one study which was published in 2019, and you can see that from baseline it had taken in 8 weeks time it would increase, but not this is the average. So in some patient it would still remain lower. So the 3 months usually is taken for complete correction of anemia in iron deficiency. So what to do if there is non-response to oral iron? So it is recommended that children with moderate to severe iron deficiency anemia, again, if you read the textbooks, the non-response to iron, the initial sentences are that if the patient is not responding to iron therapy, these are the causes you look for. But what is that non-response? We try to define it here. The patients who do not show an increase of hemoglobin of 1 gram per deciliter from baseline at the end of 2 weeks, and those with mild anemia not showing hemoglobin rise of more than 1 gram per deciliter at 4 weeks. So in a moderate and severe anemia, hemoglobin rise of 1 gram at 14 days, and in mild anemia, you wait even for the rise of hemoglobin by 1 gram at 4 weeks, and then look for what could be the cause. Certainly, during this period, you can ensure compliance to adequate dose of appropriate site. Review the history of intercurrent illnesses or infections if it is there. rule out anemia of chronic disease and chronic renal disease, and evaluate for conditions hindering iron absorption such as celiac disease. You can take the history again in detail. Look for associated vitamin B12 and folic acid deficiency. Look for occurred blood loss such as cow's milk protein intolerance, conditions like Meckel's diverticulum, inflammatory bowel disease. Look for other causes of microcytic hypochromic anemia, and beta thalassemia trait is something which needs to be differentiated. So, beta thalassemia trait can be differentiated from iron deficiency by the electronic cell counter report. You can look at the parameters like the RBC count in iron deficiency would be lower, and in beta thalassemia trait it would be more than 5 million. So cutoff of 5 million is taken, and if you divide the MCV by the TRBC, that is the Mentzer index. So Mentzer index of less than 13 is taken suggestive of beta thalassemia trait, and more than 13 is suggesting iron deficiency. And then in the causes of non-responders to oral therapy is iron refractory iron deficiency anemia, which is a genetic defect of hepcidin metabolism, and that does not allow the oral iron to be absorbed. So therefore there is iron deficiency anemia, and this is confirmed by looking at the mutation, TMPRSS gene mutation, and this is treated by giving parental iron therapy. So, moving on to macrocytic anemias, this is the same table where the macrocytosis was defined, and you can see the cutoff of serum folate, RBC folate, vitamin B12, and you also use homocysteine and methylmalonic acid these days for diagnosing the the B12 of iron deficiency. So these are the cutoffs. The common features in these patients would be mostly these patients with megaloblastic anemia are from vegetarian, poor socioeconomic class families. They are more likely to be having malnutrition compared to iron deficiency anemia. There might be bleeding manifestations or tremors, bleeding manifestations because of thrombocytopenia, and whole lot of neurological complications are there in these patients, including developmental regression or developmental arrest. Tremors, of course, are there. In addition to tremors, there are other abnormal movements are described like chorioathetosis. Microcephaly is described. Cognitive impairment, mild liver and splenic enlargement may be there, and skin and other bleeds may be there. So at times these cases may be confused with something like aplastic anemia or maybe acute leukemia as well if there is liver spleen enlargement and bleeding manifestation. So be careful when you are looking at such cases. And histogram will show you in dimorphic anemia, it will show you two peaks like you see here. Just for comparison, this is a picture of double hump camel. So this is the RBC histogram that will show the two populations of RBCs, microcytic and macrocytic. Again, going by the recommendations, the peripheral smear with presence of macrocytes and hypersegmented neutrophils along with an elevated MCV should arouse suspicion of underlying vitamin B12 or folate deficiency. And cobalamin and folate acids should be done simultaneously due to the close relationship in the metabolism, and serum folate levels should be estimated before the RBC folate levels. The RBC folate levels need to be estimated if there is a strong suspicion of underlying folate deficiency despite normal folate levels or as corroborative evidence for folate deficiency. So folate and B12 levels are required for diagnosing deficiency, and we will discuss how to treat if you do not have the levels available. Plasma homocysteine or plasma methylmalonic acid should be considered as supplementary tests to diagnose biochemical vitamin B12 deficiency in a suspected clinical situation with borderline levels. Here, it's important to remember that homocysteine is increased in the deficiency of both folic acid as well as B12. but methylmalonic acid is specific for the diagnosis of B12 deficiency. Methylmalonic acid levels are increased only in B12 deficiency and not in folate deficiency. And this test can be performed even in the urine. So, if the lab is able to do in blood, certainly that lab would be able to do in the urine as well. And now, what about bone marrow examination in children with megaloblastic anemia? So, if there are atypical clinical features in the CBC which does not corroborate the diagnosis, it is preferable to perform a bone marrow prior to initiating therapy to exclude other causes like aplastic anemia, leukemia, or myelodysplastic syndrome, which could mimic megaloblastic anemia, as I said. So, which means that if pancytopenia is there, you would definitely do a bone marrow to exclude these. So, how do we? These are the cutoffs there for low folate levels, level of 4 nanogram per ml. Again, this is WHO cutoff, and RBC folate level, which is 100 nanogram, is the cutoff for defining folate deficiency. Now, regarding B12, our recommendation was that more than 300 picogram per ml are considered normal, and in all probability, it will exclude significant vitamin B12 deficiency. Levels between 200 to 300 picogram are considered borderline, and less than 200 picogram are suggested to be used to define vitamin B12 deficiency. Again, in the presence of inflammation and malignancy, serum B12 levels may be spuriously high, falsely high. So, careful interpretation in such cases is required. The levels described for defining B12 or folate deficiency should be cautiously interpreted. The low levels only substantiate the diagnosis, but normal levels do not exclude the diagnosis in children with consistent clinical picture. There is another test which is now available, but it is sparingly available only, the holotranscobalamin. Holotranscobalamin assay has better sensitivity and specificity in identifying B12 deficiency than serum cobalamin assays. A cutoff of 35 picomoles is suggested for defining. It is still not widely available in India, but it's a test of future. Maybe you can remember that holotranscobalamin levels. So, as I said, functional deficiency of B12 and folate that you have to look at by doing serum methylmalonic acid or homocysteine levels, the confirm the diagnosis of B12 and folate levels, the deficiencies. How to treat the megaloblastic anemia? In the presence of discordance between laboratory results and strong clinical features of B12 deficiency, treatment should not be delayed to avoid neurological impairment, because if the deficiency is there, it might unnecessarily lead to neurological impairment. So there should not be a delay in starting the treatment. Mild to moderate macrocytic anemia due to dietary B12 deficiency. And please remember, in our country, most cases of B12 deficiency are dietary deficiency, particularly in children. So that can be treated with oral vitamin B12 rather than given injections. And it is recommended to give initial parenteral B12 in children with neurological manifestations, underlying malabsorption of B12, or severe anemia or pancytopenia, or in cases of disorders of vitamin B12 metabolism. So, by and large, nutritional B12 deficiency can be treated with oral B12 therapy, except when it is severe or there is pancytopenia. In patients who are started on parenteral treatment, after the initial response, maintenance therapy with oral B12 can be considered. So, without neurological manifestations due to B12 deficiency, they need treatment for at least 3 months, and those with neurological signs and symptoms need at least 6 months of therapy. Treatment of folate deficiency should be initiated only after excluding coexisting B12 deficiency. Folic acid deficiency is treated with oral folate 1 to 5 milligram per day for 3 to 4 months. So it's not per kg, it is the 1 to 5 milligram total dose of the folic acid. So when it is not possible, as I said, we will discuss it further. When it is not possible to have the levels of B12 and folate, treatment with both B12 and folic acid should be provided. B12 alone should be started in the initial 10 to 14. When you are giving megaloblastic anemia treatment without doing the Lewis, please start B12 alone for the initial 10 to 14 days, and then you add folic acid, and that is again to prevent the neurological complications. Because if you give folate, all the B12 would be drawn for the hematopoiesis, and neurological complications would start appearing, or maybe if they are already there, that would worsen. So folic acid should not be instituted alone if B12 deficiency has not been excluded. And treatment of children with dimorphic anemia should include iron therapy as well, along with folic acid and B12. So there are several preparations of B12 now available. Cyanocobalamin, hydroxycobalamin are there, and methylcobalamin, which is very widely available these days. And there are injections, oral tablets, sublingual tablets are there, nasal sprays there, and transdermal preparations have come up. I don't know why all these types of preparations are available. I thought injectable and oral tablet or sublingual were good enough. People are making nasal sprays and transdermal preparations. So, oral B12 therapy versus intramuscular, there is a whole lot of literature now which is available for treating B12 and deficiency with oral preparations, and it is regarded as effective as intramuscular administration in obtaining short-term hematological and neurological responses. Another Cochrane review which showed oral and IM B12 having similar effects in terms of normalizing B12 levels, but oral treatment costs less. So that's another advantage, right? So oral B12 is very well effective. So why it is effective is that 1% of the cobalamin is absorbed orally by passive diffusion independent of the intrinsic factor. So even in those patients who have intrinsic factor problems, pernicious, there also therapy with large doses of oral cobalamin can be effective. Daily dose required is very low, 1 to 2.5 microgram only. So large oral doses may meet these requirements. As most cases of B12 deficiency in India are of dietary origin, oral therapy can be used, as I said in the recommendations, and injectable should be used only in cases where a fast response is required or compliance is not ensured. A starting dose of only 25 milligram to be given daily by intramuscular or deep subcutaneous IV route for initial 2 to 3 days. This should be followed up by 100 microgram dose for 7 days for severe anemia and for 3 weeks in children with neurological features, then followed by 100 microgram B12 IM or subcutaneous or IV on alternate day for 7 days. So beginning with a small dose, then building up higher dose parenteral, and then followed by 1000 microgram for every week over 1 month, and starting dose of younger children, malnourished children must be lower, 25 to 50 microgram. Because if the child has severe malnutrition, in these patients there is life-threatening hypokalemia with large doses of vitamin B12 given, and there is neurological deterioration because of sudden availability of vitamin B12. There is neurotransmission suddenly increases, and we have reported in our data from Kalavati Saran Hospital some 15-20% cases who were given large doses. This is long back, almost 20 years back, when we did initial studies. The 1000 microgram dose was given, and that resulted in tremors occurring in patients with the B12 deficiency anemia. Cyanocobalamin is the synthetic form of B12 and requires conversions to methylcobalamin. Hydroxycobalamin is long-acting form. Children with pernicious anemia or inherited disorders of metabolic B12, they process these compounds poorly. Methylcobalamin is most readily available oral preparation and can be prescribed for oral therapy. Folate deficiency is treated with 5 milligram for 4 months in adults, but in children, a proportionately decreased dose of 1 to 5 milligram can be used. Higher dose to be used in children with suspected malabsorption. Now, how to assess the response to vitamin B12 or folate therapy? So when you start the therapy, there is if the LDH has been done, that would start decreasing. There would be erratic response in about 5 to 10 days time. So you can see here. And in 2 weeks' time, there is correction of thrombocytopenia. If neutropenia and thrombocytopenia were there, you can repeat plasma homocysteine and plasma methylmalonic acid levels. And then after 2 weeks, the rise of hemoglobin can be seen. And by 4 weeks, the neutrophils with the increased lobe counts would almost disappear from the peripheral blood. So failure of response, check the compliance, infections including tuberculosis, associated iron or other deficiencies. Poor absorption of B12 can be there because of omeprazole or lansoprazole. H2 receptor antagonists also interfere with absorption. And other causes like Rogers syndrome, which is thiamine responsive megaloblastic anemia, that's a inherited disorder. So if you have not carefully seen this, and this might be then picked up because it is associated with deafness and some abnormalities of glucose metabolism, and inherited defects of metabolism that should be looked for, and inborn errors of metabolism of cobalamin metabolism. So these are the causes where the response to cobalamin therapy may be inadequate. Now, as I said in the beginning, in the treatment part, the dietary advice is very important. So it is recommended that caregivers of all infants and children being treated for nutritional anemia should be counseled to improve the diet. All infants must be exclusively breastfed till 6 months. Age appropriate, adequate, and diverse complementary foods after 6 months are recommended. And for children older than 12 months, intake of milk should be less than 600 ml per day, and water should be discouraged or discontinued to limit the milk intake. As regards transfusion in nutritional anemia, I think age-old cutoff of less than 4 gram without cardiorespiratory decompensation, and 4 to 6 gram with cardiorespiratory decompensation is the cutoff which is still being used, and it is preferable to give 5 to 10 ml per kg of PEG cells. And if the patient already has cardiorespiratory decompensation, then it's better to give under cover of furosemide. What about prevention? Iron supplementation is recommended for preterm and low birth weight infants and continued in infancy until adequate iron for complementary food is assured. So I think this is something very important. Despite very good neonatal units in the country, the preterm and LBW infants are not universally supplemented with iron. Though they do studies 2 weeks versus 4 weeks at what time one should start. But it's a sad affair that the children who are preterm or low birth weight, they'll end up receiving blood transfusions in pediatric wards. So oral supplementation in a dose of 2 to 4 milligram per kg per day in low birth weight infants from 2 to 4 weeks of life till 12 months is recommended by National Neonatology Forum of India. All children, especially those with risk factors, should be screened for anemia 9 to 12 months, 5 years and adolescence. In fact, in view of operational feasibility and better compliance, intermittent iron supplementation under Anemia Mukt Bharat program is recommended for infants, preschool children and school children and adolescents, and delayed cord camping is something which is recommended for iron preventing. So we recommended that the child, when he is coming for 9 months vaccination, so that is the time when we should look for anemia by doing a hemoglobin, not clinically only. And that is the time proper complementary feeding is ensured. So actually, say 10, 6, 10, 14 weeks, that is the immunization visits, and after that, practically if the child has stayed well, then the visit is after only 4 to 5 months, that is measles vaccination. So at least at that point in time, one should look at the hemoglobin level and ensure that the complementary feeding is being given very well. And age appropriate this iron supplementation is started. And after treatment of all children with iron deficiency anemia or other deficiency anemias, please associate them with the national programs. Tell them that they should go to the Anganwadi or wherever the iron supplementation is being provided. And please remember that if one child in the family is iron deficient, maybe the older sibling or younger sibling also could be iron deficient. So do not forget to screen the siblings for anemia and take care of those siblings as well when you diagnose that they are anemic. So, just to conclude my talk, all patients should be assessed for anemia clinically whenever they come with their whatever intercurrent infections or whatever problems are there. Proactive approach, look for anemia, hemoglobin estimation at 9 months, 5 years under adolescence. During first and second immunization visit, see if the infant is high risk for anemia, start iron if it has not been done so. Emphasize exclusive breastfeeding for 6 months. Spend time with the mother on counseling. Counsel or review on complementary feeding. Use 9 months vaccination visit for this. Treat iron deficiency anemia with single dose of 2 to 3 milligram. Emphasize on need of therapy and completion of the therapy. Assess the response to iron replacement therapy as discussed earlier. Document the response. Investigate for cause of non-response if required. Attach to Anemia Mukt Bharat program for prophylactic iron supplementation. Treat the underlying cause whenever identified. Look at the siblings. If B12 and folate levels are not done, patients with macrocytic anemia to be treated with both micronutrients. Initial treatment of megaloblastic anemia in such cases would be with cobalamin and not with folate alone. Most cases of B12 deficiency can be treated with oral methylcobalamin. Patients with neurological symptoms or severe anemia need parenteral therapy, and initial doses of cobalamin should be low to prevent hypokalemia. So I think this is the last slide. If there are any questions, I would try answering them. Thank you.
Thank you, sir. Very excellent talk, and that is quite evidence based. And you have, in fact, answered most of the small you can queries. In fact, today, last 3 days we are having a training on IMNCI, and a lot of questions were asked on this iron deficiency anemia on this thing. And for practically also, there are a lot of things like when to start iron, how much to give, and all those, and what about vitamin B12 and all. So you have answered that. I also encourage the students to read that article on Indian pediatrics which Sher has given in the initial part of his lecture. It has got all the details of according to evidence. Before I open the house for questions, which will be there on the chat box, sir, just sometimes now most of the preparation come with iron and folic acid. Now we're telling, like, for example, folic acid should not be started, but suppose inadvertently vitamin B12 is missed. So there is a possibility, yes, it's a because
yes. There is always this is a theoretical possibility always, because somehow with the program when it started 60 years back, the iron folate supplementation was started, and I think there is hardly any preparation of actually.
Yes.
We cannot do iron studies, iron supplementation studies, because always there is a folic acid in that. So there is a theoretical risk, but then practically we have not seen, because the doses of folate in that are just therapeutic doses and they are low, so that will not result in very significant hematopoiesis. So I'm sure, but there is, as you have said, theoretically there is a risk of deterioration of B12 deficiency.
Right, sir. Thank you, sir.
In dimorphic anemia, I would suggest that in dimorphic anemia, if iron folate has been started, so one has to be careful, and in the follow-up, should we look for if there are any problems of that kind.
Yeah. Now, with this anemia, with knowing more about B12 and all, we should always try to look at the PS pictures and.
Your voice is getting interrupted.
No, I think I was getting a call actually.
Okay.
One more thing, sir. You'll be pleased to know there are about 320 students till the end of the lecture. So that is question number of students. Now coming, sir, there are a few queries on the chat box. You can mobile, you can see. I can only ask. Chat, like, Why iron should be given in acute, not given
Why
in
iron
acute?
should not be given. Okay.
Yes.
Okay. So actually, iron is also required for bacteria to multiply, and the free availability should not be provided. So the acute bacterial infections do worsen. That is what is the theory behind not giving iron therapy to acutely infected cases. And anyway, if you are giving iron, the response will not be there. So both the things are there, and since the response is not there, why exposed to a potential complication?
Right, sir. In cases of hyperferritinemia cases, what to do?
What is that? Okay. In cases of hyperferritinemia cases, how we can diagnose the iron deficiency anemia? What is that? Hyperferritinemia.
Hyperferritinemia.
As ferritin,
I thought the question is
first for making iron deficiency. No, the sentence I can read. In case of hyperferritinemia, how we can diagnose the iron deficiency anemia? As ferritin, we need to take first for making iron deficiency anemia. So if there is ferritin is high, where is the question of iron deficiency? So if the ferritin is really high, that iron deficiency practically excluded. That's what there's some confusion in writing probably.
Maybe what he's talking about acute phase reactant coming into play, and that's what.
Okay. In that case, one has to wait. Probably the acute infection has to subside, and then only, yeah.
Right.
Can prophylaxis of albendazole prescribed to every patient of iron deficiency? Actually, that is in the national program. We have not put it in the treatment because this is there in the national program, and every child every 6 months above the age of I think 6 months they recommend using. So that is there. That should be given. And if the patient has not received in last 6 months, there is no harm in prescribing during the treatment.
Withholding iron therapy during illness.
Whenever, wherever be the focus, or is it during enteric infection only? Again, non-response during infections would be the reason why we should not give during the infections. What is the best IV preparation? Okay, for less than 5 years of age. Okay, if you want to use, actually these days iron sucrose has become available, and that is commonly used. So one can use that for giving to children as well. And I had not specifically looked at these, but I can tell you what are the other iron preparation which are recommended in children. I can just.
I think connectivity is now breaking. Saurabhji, can you hear my voice or Dr. Jagdish sir's voice?
So this is the iron preparations which are actually nowadays IV is recommended, not the intramuscular. So the iron sucrose is commonly prescribed, and ferrigluconate is another which is approved for children, and this is the iron sucrose is the most common IV form that is prescribed. This is recommended for.
Sir, iron preparation, most of them do teeth staining. Are there any preparation that, it will be there with each and every iron preparation, is it?
So liquid preparations will do that, and with that I think I always advise that usko thoda sa uske baad mein pani pila do.
Okay, give water after that.
So,
okay.
And withholding, what is the best iron preparation? IV iron preparation. What are the others? Sir, any iron formulation to be preferred over the other for better compliance? Actually, the teeth staining, I don't know if iron ascorbate or polymaltose complex will have less teeth staining, but these are the preparations which are said that they are better tolerated. I do not have a personal experience, but literature says that they are better tolerated. So if there are issues with gluconate and fumarate, one can go for iron ascorbate, but then cost would be too high.
Sir, one more thing in between I'd like to ask. While advising to give, what is the relationship with food? You normally say give it after 1 hour after food, not with the food. Is it mandatory to advise that with all the salts?
Yeah, actually, the absorption is not all that good if you give after food because of that the food contains several things, phytates, etc., and that would interfere with absorption. But the compliance is better. The adverse effect, the GI adverse effects are less.
Much
So
less.
one has to balance between the two, and compliance is more important. Therefore, we tend to give with the 2 to 3 milligram. The adverse effect will not be too much, but then still it is preferred to give. I prescribe avoiding giving with milk. That leads to milk and the calcium preparations. It should be away from those. So, and these days there are several cases who come with rickets or vitamin D deficiency also. So in them you are prescribing calcium BD and iron OD. So that can be spaced out, like morning, evening calcium, and in between in the daytime the child can get iron. So should we give B12 along with IFA in nutritional anemia? Well, I think it's not like always you give all the 3 macronutrients. So the entire discussion would be fruitless if you want to give all the 3 drugs. How does high dose vitamin D starting leads to hypokalemia? Okay, hypokalemia is on account of increased the RBC synthesis, and there is increased intracellular movement of the potassium. So therefore, the serum levels decrease. So the discrepancy between serum and this level that can result in problems. So that is the mechanism of giving hypokalemia occurring, and this particularly in patients with severe malnutrition because they already are say low levels of body potassium are there. Role of blood transfusion to treat anemia, I think I talked about that, and as I said, 4 to 6 gram hemoglobin with cardiorespiratory distress and less than 4 even if there is no cardiorespiratory distress, and that is from the same 10 steps guideline that is being recommended throughout the nutrition anemia also. When should iron prophylaxis to be started in term and preterm babies? We said 2 to 4 weeks. Term infants 6 months. Term infants is 6 months and preterm is 2 to 4 weeks. Why iron is not given in first 2 weeks in LBW babies? Probably I don't know the answer to this. Why not in 2 weeks? In the initial 2 weeks. I don't know what is the reason for that. In fact, this 2 weeks has become earlier because earlier it used to be even later, that 4 to 6 weeks or more. But I don't know if anybody has used in 2 weeks and found any abnormalities or any adverse effects because of that. Frankly, no answer for that. What is the screening test for anemia at 9 to 12 months? Screening test for anemia. The hemoglobin. One has to check the hemoglobin. What about HB deficit formula to give iron HB deficit formula to give iron supplementation? That is parenteral. One is trying to know. Hello?
Sir, I think there's some issues with the connectivity.
Okay.
I think we end here because now we're not getting the question. But it was an excellent class, and I'm sure students can go back and read the article in pediatrics. They will have a much, they can get the answers from there as well. Thank you very much, sir, for your